at the Royal College exam, you will be presented with a case. The case will start with history, then all the imaging tests associated with it. The case takes about 5 minutes. So I will be timing each case for 5 minutes and then 1 minute for feedback. So I will present you with the history first, and then when you are done with the history, just ask me to move on to the next slide, and then I'll move on to the next slide. The case may have more than one imaging modality, but may have just one imaging modality. So the case may just have an MRI, or may have X-rays or ultrasound. So it depends on the case that we are looking at. So I'm gonna just, okay, so we'll start with the first case. Do we have a resident?
Okay, دكتورة إيناس طه. دكتورة إيناس.
نعم، صباح الخير.
صباح الخير.
Okay, so we'll, yeah, we will be, sorry, just 5 minutes for the case. I'm gonna time the case now. So I'll start with the history first. Okay, if you finish with the history, let me know, and then I move on to the next slide. Are you finished with the history?
Okay.
تفضلي إيناس.
أستاذ. MRI of the knee joint, sagittal, coronal and axial view, T2 fat side, and proton density. Sure. Bone marrow edema at the femoral and tibial portion posteriorly, and anterior portion of the femur. Mild joint diffusion. The PCL is يعني not ما أقدر أشوفه واضح هنا. I think يعني it's PCL rupture. There is plica in the axial view. يعني الباتيلر تندن لا أشوفها كأنه أكو باتيلا ألتا. This is the finding I observed. يعني المنسكس دا أشوفه نورمال، ما دا أشوف abnormal signal بالكورونال فيو. Mild diffusion. يعني هاي الفايندينج اللي دا أشوفها ACL تير وفيوجن
Okay, sorry. You said ACL,
ACL
fusion.
ACL وفيوجن ويعني إديمة. هاي الفايندينج دا أشوفها أستاذ.
Okay, so you finished?
Yes.
Okay, yeah, I mean, you did well. Some of the observations are good. I don't know how you do the exam in Canada. So in order not to waste a lot of time on describing the MRI sequences, unless it is a requirement in your local training program. So here we can just say multiplanar multi-sequence MRI scan of the knee. That's kind of your introduction to save you time, because they only give you 5 minutes.
Okay.
So multiplanar multi-sequence MRI scan of the knee. Now, if you have any findings that are, for example, signal change, then you would have to describe the sequence. So for example, if you said high signal intensity in the lateral femoral condyle, you would say on the sagittal PDFS. Because signal intensity change on the PD or T1 or T2 may mean different things. But at the beginning, to start with, you just say multiplanar multi-sequence MRI scan of the knee. And then you take a little bit of time to just see what's going on and describe the pathology, describe the findings. So what do you think? So you said there's bone marrow edema here. What do you think the pathology is?
يعني pivot injury.
Sorry?
Pivot injury.
Pivot shift.
إيه.
Okay, so pivot shift injury, yeah, because it's lateral femoral condyle. You said bone marrow edema and the femur and tibia. It would be nice to say bone marrow edema in the lateral femoral condyle and lateral tibial plateau.
Lateral. Yes.
Because that would mean it's a pivot shift injury. Yes, you have ACL tear for sure. I don't think you described the medial collateral ligament tear.
Yes.
And also, yeah, I don't think you described medial patellofemoral ligament tear. So this is medial patellofemoral ligament tear at the femoral attachment. There's also capsular tear. That's why you see joint leak, joint fluid leak in the soft tissue in the intermuscular compartment. So yes, it's pivot shift mechanism of injury with ACL tear, medial patellofemoral ligament tear, and medial collateral ligament tear, and joint effusion, like you said. I'm not really sure. This could be a plica, but could be a synovium as well. But anyway, you made very good observations, but you just need to, sometimes we just need to fine tune your description so then you can make it a very accurate description of the injury or pathology. Okay, let's move on now to the next case. Do we have a resident before I start the timer?
دكتورة تراث.
نعم أستاذ. نعم
تفضل.
أستاذ صباح الخير.
Hey, so I'm going to start the timer now, 5 minutes.
Yes. Yes. There is a multiple sequence MRI of the shoulder. There is a multi-related cystic lesion, hyper intense lesion adjacent to the shoulder. The deltoid, also there is a deltoid muscle appear to be high signal intensity. Otherwise, the humeral head of normal signal intensity. And this lesion appear low on T1, low on T1, and high signal intensity on T2. The labrum يعني on sagittal imaging the labrum not clear يعني the section not appear completely in the section, so we can't judge if there is a labrum injury. And also there is abnormal high signal intensity in the supraspinatus tendon at its insertion side. This cystic multilocular cystic lesion could be causing an entrapment of this is a site of the axillary nerve. So this is could be this يعني explain the fat or high signal intensity of the deltoid muscle.
Or if you finished, you can say I finished. But if you're still taking your time.
Yes, I think there is an entrapment of the axillary nerve. This is causing fatty atrophy of the deltoid muscle. By this multilocular cystic lesion could be parameniscal paralabral cyst, or could be could be a ganglion cyst.
So are you finished?
Yes.
Yeah, okay. So yeah, when you finish, just say I'm finished and summarizing. So normally what happens in the 5 minutes, you read the history and then you move on to the findings, give differential diagnosis if you can, and make further recommendation.
بس عفوا دكتور، صوتك يعني شوية ما سمعت شنو آخر شيء قلت، لأنه الصوت يعني قطع يمي.
Yeah, so the system we have here at the Royal College is describe the findings, interpret the findings, give differential diagnosis, narrow it down to one. So this is the system we have. Okay.
Yes. Yes.
So this is the system. Have this kind of approach to the cases. So always these are the 5 steps. Describe and handle each case. Okay, so for example, in this case, you are right. You said there is originating from the labrum here. And you said entrapment of the axillary nerve, which is also good. It's really when you have a paralabral cyst causing entrapment of the axillary nerve.
Yes.
What's the name of the condition?
This is a lateral triangle space syndrome.
Okay. Quadrilateral.
Quadrilateral. Sorry, quadrilateral
Yeah.
space syndrome. At this
Yeah,
space, there is
quadrilateral space syndrome.
yes. At this space, there is entrapment of the axillary nerve.
Okay, so the axillary nerve supplies which muscles?
Deltoid and teres minor muscle.
Okay, so you said deltoid is edematous. I know you
Yes.
said fatty atrophy. It's actually not. Sequences are fluid sensitive, fat saturated. So any
Yes.
fat will be suppressed.
Yes, sorry,
So
this is
the fat is suppressed.
Yes, and this is edema because of denervation.
Yeah, so it's
not fat
okay,
denervation.
so
Yes.
yeah, so it's not fatty atrophy. It's denervation myositis.
Yes.
Okay, denervation myositis. Now, which muscles are involved? If you look at this sagittal image here.
And the sagittal.
So which muscle is this one?
Yes, this is deltoid muscle.
This
muscle, and this is teres minor muscle.
Yeah, so we have axillary nerve entrapment, two muscles showing denervation myositis due to paralabral cyst causing quadrilateral space syndrome. And then remember the 5 steps we said: describe, interpret, differential diagnosis, narrow it down to one diagnosis, and make further recommendation. So what further recommendation will you make?
Could be further recommendation could be ultrasound of the shoulder joint.
What's the gold standard imaging test for labral tear?
Labral tear could be MR arthrography.
Yes. So remember, this is a routine MRI.
Yes. Yes.
This is not MRI arthrography.
Yes. The next step is MR arthrography.
MRI arthrography is the gold standard for labral tear. So we make a recommendation before surgery. We always make a recommendation for MRI arthrography before surgery, because the tear could be a small tear or could be a big tear. That will change the surgical management for the orthopedic surgeons. So they need MRI arthrography to see how big the tear is before they go in arthroscopically to repair it. Okay. All right. Thank you. Move on to, do you have a resident before I set the timer?
دكتورة صابرين.
نعم أستاذ، صباح الخير.
صباح الخير، تفضل.
Again, 5 minutes starting now.
Okay. Frontal view or AP view of the both pelvis and hip joint, showing there is abnormal destruction of the metaphysis of left femur, particularly at the neck. And there is decreased bone density with abnormal destruction of metaphysis associated with يعني hypodense lesion and there is cortical destruction. Mainly, there is no obvious periosteal reaction, no obvious soft tissue mass. So we're dealing with the case either with septic arthritis or with osteomyelitis, even with eosinophilic granuloma or يعني bone tumor. So we recommend further investigation and further assessment by MRI. Yes, there's a multi-sequence, multi-plane MRI of both hip joint, showing there is mild joint effusion at left hip associated with the abnormal signal intensity, mainly at metaphysis, and the prox of the left femoral neck, which is mainly high in T2 and low in T1. So we are dealing with the case of mainly osteomyelitis. There is no يعني obvious periosteal reaction, no obvious soft tissue يعني edema or infection, and there is a narrow zone of a transition. So we're dealing with either septic arthritis or osteomyelitis. Or even eosinophilic granuloma can be put in the differential. There is no obvious cloaca. So I finish my finding.
Okay, yeah, thank you. Very well. Sorry, the internet is not doing very well. Okay. Hello.
استاذ هارون شوي الصوت
Hello.
يتقطع احيانا.
Yeah. Okay. Okay. Do you hear me okay now?
Yeah.
Yes.
Okay, so let's go back to these images. Why did I give you two images here?
شنو دكتور العفو؟
So why do you have two radiographs here?
Because of multiple sequences.
Okay, so this radiograph is from September 1st. Okay, this radiograph from September 1st, this radiograph from September 10th. It's 9 days, okay, 9 days between the radiographs.
Yes.
And how do you describe the destruction? Is it aggressive, rapid aggressive, or is it slow?
Yes, there is rapid aggressive bone destruction.
Okay, so if it is rapid progressive bony destruction, with that of infection or tumor?
Could be the infection and could be the tumor. Because the age of the patient is child, and bone destruction, aggressive bone destruction in the child is goes mainly with the infection, and then the tumor, especially a period of 9 days only.
Yeah, so when it is so rapid bony destruction within 9 days, it is most likely infection rather than eosinophilic granuloma.
Yes.
Eosinophilic granuloma will probably take weeks to destroy the bone like this. Okay.
Yes.
Okay, so that's one thing. So that's the reason why I have two X-rays. Okay, showing you the date. Okay, so the reason why you have two X-rays with the dates is to tell you that this process is a rapid destruction of the bone. Okay, so the other thing is, what do you think is going on here in the right femur? Again, this is the first one and this is the second one.
There is also يعني early affection of the right femoral metaphysis by mainly the same process.
Okay, so yes, on the MRI scan, you said there is septic arthritis. I think most of the description you emphasize the changes in the left hip and in the left femur. I don't think you commented on the right hip.
Yes.
Okay, so what do you think is going on in the right hip?
The same infectious process دكتور يعني started to affect the right يعني femoral metaphysis only يعني also.
Okay, so it is septic arthritis and osteomyelitis of both hips and both femora. Okay, bilateral. It's worse on the left. It's worse on the left, but it's actually bilateral on both radiographs and the MRI. Okay, so always when you are looking at an imaging test, always make sure you search for another abnormality or another findings. Sometimes we get fixated on the effect side and then we don't pay attention to the rest of the radiograph. So make sure you look all around, make sure you check every bone and make sure you check tissue and everything. So then your description is more thorough and more comprehensive.
Okay.
Okay, so you remember what we said: describe, interpret, differential diagnosis, one diagnosis, further management. What would you do in terms of further management?
We start يعني through antibiotic treatment, antibiotic treatment to يعني saving both hip and to treat the infection. Even so, we can do a joint aspiration and culture the aspirated fluid to detect what's the type of the organism affecting both the hip and then giving the treatment accordingly.
Yeah, so your further management, we don't, as radiologists, we don't give antibiotics. So our role as radiologists is actually to inform the referring physician about these urgent findings. So normally we call them, we give them a verbal report that the MRI scan is showing septic arthritis and osteomyelitis of both hips and both femora. So this patient can be admitted, can be hospitalized, and can be given intravenous antibiotics. And obviously, like you said, before they give antibiotics, they have to do joint aspiration for microbiology, culture sensitivity, and then they start the antibiotics. So yeah, remember these 5 steps: describe, interpret, differential diagnosis, one diagnosis.
Okay.
In the case of the resident,
دكتورة دينا حمود.
نعم أستاذ، صباح الخير.
صباح الخير.
Okay, starting now 5 minutes.
Yes. And two view of ankle joint, lateral IB, and oblique view. That is decrease bone intensity seem to be in the talus and calcaneus, and more obvious on the talus. Slightly widening the joint space. يعني أستاذ يعني اللي واضح أكثر شيء الثالث هو أقصد decrease bone density and had lucent lesion involving the talus bone. يعني هذا اللي دا أشوفه بالإكس-راي. يعني seem to be with the many well-defined narrow zone of transition. No other finding. Yeah, no joint effusion, no soft tissue edema. If there is any MRI.
Sorry, are you making a recommendation?
Sorry, Ustaz?
Are you making a recommendation for further imaging with MRI?
Yes.
So before we move on, are you going to maybe be more descriptive, or okay, let's show you the MRI.
Yes, I'm not section MRI of ankle joint. There is a well circumscribed lesion appear involving the talus, appear hypo-intense in T1 and hyper-intense in T2 and STIR. In a well circumscribed narrow zone of the transition with يعني hypo-intense rim seem to be يعني sclerotic border. With mild joint fusion. And the soft tissue edema يعني appear بالستر. And it seems to be lesion يعني عبارة عن lesion with no aggressive feature, narrow zone of transition with the slightly bone marrow edema.
Okay, we only have 20 seconds left. What's your differential diagnosis or diagnosis?
يعني أستاذ هو هايبو سيجنال يعني هايبو T1 هايبر T2 يعني ممكن simple cyst نخلي simple bone cyst or ganglion intraosseous ganglion.
Okay, yeah, time is up. Time is up. Okay, yeah, so this is an interesting one for sure. The description, the reason why I ask for more description on the radiographs is because, so the way to describe this lesion, you would normally say there is subarticular lytic lesion in the talus with narrow zone of transition, no collapse of the articular surface, no periosteal reaction, no extraosseous mass. So this is how, remember from the bone tumor talk, we talked about radiographic description of bony lesions. And it's a list of imaging features on the radiographs that you need to describe. And the reason why you need to be more descriptive on the radiographs is because your description of the lesion on the radiographs will determine whether the lesion is aggressive or non-aggressive. And then based on that, you would make a recommendation for further imaging. So if we just had the radiographs here without MRI, and I told you there is a lesion that is subarticular in the talus with narrow zone of transition, what would you think of in terms of differential diagnosis?
يعني أستاذ هو الأكثر يعني مع الكريتيكالي ماتشور بيشنت وعندنا ليثيك ليجن with narrow zone of transition subarticular يعني نخلي الجوينت سيل تيومر first differential.
Yeah. So this is a skeletally mature patient, and it's a subarticular lesion. If you remember from the bone tumor talk, we said the differential diagnosis for subarticular lesions depend on the patient's age. In an adult like this patient, we would think more giant cell tumor, just like you said. And in a child, we will think of
aneurysmal bone cyst.
We'll think of chondroblastoma.
Oh, chondroblastoma, yes.
Yeah, so the
Sorry,
subarticular
aneurysmal bone cyst metaphyseal lesion, yes. Sir.
Yeah, okay. So that's why I wanted you to be more descriptive on the radiograph before I showed you the MRI, because the term subarticular is very specific. There's only 3 or 4 tumors or lesions that can be subarticular like this. Okay, this is very, very subarticular. So it's chondroblastoma in a child, giant cell tumor in an adult, clear cell chondrosarcoma, degenerate cyst, yes, also can be subarticular, but there is no degeneration. So we cannot say ganglion cyst when the joint is so clean. Okay, there's no degeneration of the joint. If we had osteoarthritis of the joint, then we will be talking about maybe a geoid cyst or degenerate cyst or a ganglion cyst. But this is a young adult with normal joint space otherwise. They just have a lytic lesion in the subarticular space. And on MRI scan, that quite clearly demonstrates the tumor of the, I don't know if you actually identified that this is T1 fat sat post contrast showing enhancement. So this is not a cyst, okay, because a cyst would be dark on the sequence, will just have peripheral enhancement. But this is solid mass, solid tumor showing enhancement. And it's in the subarticular area. There is surrounding osseous edema. There's surrounding soft tissue edema. There's also cortical breakthrough here anteriorly, okay? And there's also joint effusion, like you said. So this is a giant cell tumor of the talus, okay? And you could tell actually the differential diagnosis or the diagnosis just based on the radiographs. The MRI scan was done here just to assess the biopsy direction of the biopsy and assess for cortical break. So really, the role of the MRI is for local staging for malignant tumors, but also be useful for detecting or deciding on which way to go in for the biopsy. Okay.
Yes.
Right. Okay. Now, do we have another resident?
دكتورة سجاء.
نعم أستاذ صباح الخير.
صباح الخير.
Okay, 5 minutes starting now.
Okay, next.
تفضلي دكتورة سجاء، استغلوا الوقت 5 minutes عندكم.
نعم
ديسكرايب مثل ما علمكم أستاذ هارون. ديسكرايب give differential diagnosis, give the exam type. يلا بنتي تفضل.
X-ray of the AP and lateral of a skeletally mature skeleton, showing decrease medially decrease in joint space and subchondral sclerosis and increased density and subchondral sclerosis in the medial joint space. Also, I can see there is increased density in the lateral joint space. In the side of the lateral meniscus, there is increased density. There is the bone look normal, and there is no soft tissue swelling, no joint effusion.
Is it
normal,
the bone? Is it normal?
I think it's of decrease density, decrease bone density.
What about the trabecular pattern?
Coarsened trabecular pattern with decreased bone density, but there is subchondral sclerosis. Yes. There is also, I can see there is cortical irregularity in the subarticular, not subarticular, يعني it is not articular, cortical irregularity involve both surface, not the surface, below the surface of the tibia.
What about the coarseness of the bone? Is it normal or
abnormal? Increased trabeculation. I think it's intrinsic. I give different versus Paget disease. For this abnormal trabeculation. I recommend further MRI. Multiple sections MRI showing there is a sagittal view showing abnormal signal intensity in the lower end of the femur and the proximal tibia, and also there is subchondral abnormal low signal intensity involving the medial aspect of the femur and surrounded by peripheral low signal run. This is associated with the surrounding soft tissue edema. I give differential diagnosis for this chondral bony defect. Osteochondritis dissecans. There is only edema, and this is not detached and not displaced. But here the bone intensity look normal. There is no abnormal trabeculation or something like appear in the X-ray. There is no soft tissue, no joint fusion.
Okay, we have about 10 seconds left. So are you finished?
Yes, it's a subchondral bony defect, osteochondritis dissecans. And stage, it's stage 2. Yes.
Okay.
Further.
Yeah, go on.
I think the further management, I refer to the doctor for medical treatment.
Okay, yeah, you did really well. You described the subchondral sclerosis here in the medial femoral condyle, which I'm really impressed that you described it here very well. So that was very subtle, not easy radiograph, to be honest with you. It's a difficult one, this one, and I wouldn't be disappointed if anyone missed the subchondral sclerosis, but it's a subtle one. It's a really difficult one. You did well on the MRI as well. You described the pathology. There is subarticular line, hypointense line surrounded by edema on the weight-bearing surface of the medial femoral condyle. I think the pathology here is, you called it subchondral, but then you said osteochondritis dissecans. So these are two different entities, what you described. The osteochondritis dissecans is avascular necrosis. It's avascular necrosis of the osteochondral part of the joint. This is not osteochondritis dissecans. This is subchondral insufficiency fracture. It used to be called SONC, spontaneous osteonecrosis of the knee, but they changed the terminology from SONC to SIF, subchondral insufficiency fracture. Now, how do you differentiate between osteochondritis dissecans and SIF? The history is very important. So if you read the history, it's sudden onset, right knee pain, medial joint space. With osteochondritis dissecans is not a sudden knee pain. It's AVN of the articular surface of the joint, which happens over weeks and sometimes even months for the patients to present with knee pain. But when it is sudden, it is subchondral insufficiency fracture. So they break the bone in the subchondral region here, okay, and they present acutely with pain. So this is what subchondral insufficiency fracture look like on X-ray and also on MRI. Okay. Yeah, some people already talked about SONC. So SONC is the old terminology. The new terminology is SIF. Okay. Do we have another resident before I set the timer?
دكتور هشام سليم.
نعم أستاذ.
تفضل.
تمام.
Do you want me to move on?
Yes. This is a pelvic radiograph involving the pelvis and both hip joints. Of skeletally mature patient. There is a radiolucent lesion in the right inferior pubic ramus, poorly defined with a wide zone of transition. I can see an associated soft tissue swelling. No osteoid matrix or chondroid matrix. No obvious periosteal reaction. So I recommend doing MRI. So multiple section MRI. There is an extensive soft tissue density lesion, iso-intense, seen involving the inferior pubic ramus with soft tissue extension into the pelvis, showing aggressive enhancements after contrast. So the differential here will be lytic metastasis or multiple myeloma. The third differential will be lymphoma. So in summary, there is an extensive lytic lesion seen on radiograph involving the right inferior pubic ramus with wide zone of transition. And by MRI, there is an isointense lesion seen with significant enhancement post-contrast involving the inferior pubic ramus with extension into the pelvis. The differential diagnosis will be the lytic metastasis, multiple myeloma, or lymphoma. I finished, sir.
Okay, yeah, thank you. You did well. Just need to go over this case together. Yes, so the radiographs showed the lytic lesion in the right inferior pubic ramus. And again, I just want to remind you about what we talked about with bone tumors. When we described bone lesion on the radiographs, after your description, you should really commit to whether this is an aggressive lesion or non-aggressive lesion. So please remember this, because we do not necessarily recommend MRI scan for lesions that are non-aggressive on the radiograph. So when you request an MRI scan, there is a reason why you request an MRI scan. So when you describe this lesion, as you described it really well, you said there's lytic lesion in the right inferior pubic ramus with wide zone of transition, no other bony lesion seen, no soft tissue mass. And again, comment on any periosteal reaction. And then you would say, because it's lytic and it's wide zone of transition, I think this is an aggressive bony lesion. And because it's an aggressive bony lesion, I would recommend an MRI scan. So this would normally be your approach for bone tumors on the radiographs. So please remember the description. And then at the end of the description, you should commit to whether aggressive or non-aggressive. And on MRI scan, again, a reminder that the MRI scan is done when we have an aggressive bony lesion on the radiograph, and the MRI is done for local staging. And if we are doing local staging on the MRI, then we should comment on the neurovascular structures, we should comment on the intra-articular extension, we should comment on the fat plane between the mass and the pelvic organs. So this is how you would normally describe the MRI scan in patients with an aggressive bony lesion. In terms of the differential diagnosis, you said there is an associated large extraosseous mass. And I like that description, because it is the extraosseous mass that actually is going to narrow down your differential diagnosis. There's only two in an adult skeletal immature patient with a tumor arising from a flat bone, like the pelvis. There's only two pathologies that actually can give you an aggressive lytic bony lesion with a large extraosseous mass like this one. What are the two, if I may ask you the question, in an adult with a flat bone tumor, aggressive with large extraosseous mass, what are the two tumors that would normally cause this pathology?
Multiple myeloma and RCC metastasis.
Okay, so multiple myeloma, we need to make a distinction between multiple myeloma and plasmacytoma.
Yes, plasmacytoma.
Yes, so this would be a plasmacytoma rather than multiple myeloma, because remember, the pathology is different between plasmacytoma and multiple myeloma. The other pathology that actually can cause flat bone tumor with large extraosseous mass is lymphoma. So I know you put lymphoma as the third differential diagnosis on your list, but actually it should be the first one on your list. So you would say, because it's a flat bone tumor, aggressive with large extraosseous mass, then my primary diagnosis will be lymphoma. The second alternative diagnosis would be plasmacytoma. So really, your differential diagnosis only two pathologies. And in terms of further management, you would recommend image-guided biopsy for this one after consultation with the sarcoma surgeon. So the biopsy would ultimately decide whether this is actually lymphoma or plasmacytoma. So yeah, this is just the feedback on bone tumors. Okay. Now, do we have another resident?
دكتور سامر. دكتور سامر شاربة. دكتورة شراء خالد.
نعم أستاذ، السلام عليكم.
تفضل.
اوكي استاذ، بس الصوت ده يقطع بس. اوكي شفت الهيستوري تمام. نيكست. نيكست بليز. استاذ مدى اسمعك؟ الو تسمعوني؟
نسمعك بس استاذ هارون ما نسمع.
تمام.
استاذ هارون الصوت مو واضح.
اوكي استاذ، اي سي ات.